Hey guys, this is Shubham, and today's topic is antihypertensives. Anti means against, and hypertensive is hypertension. So that means these drugs are gonna act against hypertension. Now we should know about hypertension. Some words about the hypertension. What is hypertension? Hypertension is actually the condition in which there is increased blood pressure. So increased blood pressure is the another name of hypertension. So normally our blood pressure in our body is 120 over 80. So 120 is systolic blood pressure and 80 is the diastolic blood pressure. Okay, so 120 millimeter of mercury is the systolic blood pressure and 80 millimeter of mercury is the diastolic blood pressure. These are the normal units of the blood pressure. However, if there is increased in units, in these units, there will be a fluctuation in these units, then we termed it as hypertension. For example, in systolic, if we see, if there is above 140 millimeter of mercury, then this term is called as hypertension. So antihypertensives, they act against increased blood pressure. So they try to reduce the blood pressure anyhow. So we have different classes in the antihypertensives, and we can remember it with the alphabetic mnemonics like A, B, C, D, and E. So A, B, C, D, and E. With this mnemonic, we can remember the various kinds of classes of the antihypertensives. So from the A, starting with the A, what is A? A is alpha 1 blockers. Alpha 1 blockers. Okay. Also with the A, we have angiotensinogen converting enzyme inhibitors. So angiotensin converting enzyme inhibitors. Angiotensin converting enzyme inhibitors, or ACE inhibitors. Okay. And also with the A, we have angiotensin 2 receptor blockers. So angiotensin 2 receptor blockers. Angiotensin 2 receptor blockers, they are also called as ARBs. ARB. So these three classes, named under the A, you can remember it with the A with the alpha 1 blockers, angiotensin converting enzymes inhibitors, that is ACE inhibitors, and angiotensin receptor blockers, or ARBs. With the B, we have beta blockers. Beta blockers, either beta 1 blockers or both beta 1 and beta 2 blockers. With the C, we have calcium channel blockers. Calcium channel blockers. D is the diuretics. And in last E, that is endothelin 1 receptor blocker, or you can say endothelin receptor blocker. In this class, we have the vasodilators. Okay, so this is very wide classification as far as antihypertensive are concerned. So these are the different classes, and they act against the increased blood pressure. They try to reduce the blood pressure anyhow with the different mechanism of actions. So I will talk about them one by one. So firstly, let's talk about the alpha 1 blockers. Actually, alpha 1 blockers, they act on the receptors, that is adrenergic receptors, alpha 1 adrenergic receptor, that are present in the smooth muscle cells. So for example, talking about the first one, that is, let's classify them. They are the first, second, third, fourth, and fifth. So let's talk about the first one, alpha 1 blockers. So alpha 1 blockers, in the smooth muscle cells, they are the receptors that are alpha 1 adrenergic receptors present on the smooth muscle cells. So what happens over there actually? For example, this is the smooth muscle cell. For example, this is the smooth muscle cell. Okay, over here, this is the receptor. This is the, for example, this is the alpha 1 adrenergic receptor. Okay, on the smooth muscle cell. This is the smooth muscle cell. This is the smooth muscle. So alpha 1 adrenergic receptor are present over here on the top of it. So what happens? For example, here is the adrenergic neuron. This is the adrenergic neuron. So what they will release? They will release the adrenaline or epinephrine. So that will bind, that can bind to this receptor. And as they will bind to this receptor, they will produce the action potential and the smooth muscle will contract. This is the physiological condition. So this smooth muscle will contract, and around it there is the lumen present over here. So for example, this is the lumen, okay, in which our blood is moving, our RBCs, WBCs, those cells are moving in the blood, along with the blood. So as the smooth muscle will contract, the lumen will begin to constrict. So as the lumen will contract, you can see. So as the smooth muscle will contract, as they will contract, so the lumen will begin to shrink. So the lumen will bring to shrink. And as these vessels, the blood vessels will shrink or will constrict, the blood pressure will increase. Okay, so this is the physiologically how blood pressure increase in these circumstances, that if the smooth muscle will contract, our blood pressure increase. Why blood pressure increase? Because the lumen of the blood vessels, as the smooth muscle contract, so they will also constrict, they will also contract. That's why the blood pressure increased. Okay. Now, how alpha 1 blockers help in this situation and helps to get over the increased blood pressure? They will try to reduce the blood pressure. That they will come over here. For example, these are alpha 1 blockers. Okay. What they will do? They will come over here and they will block this receptor. Okay. Over here they will block this receptor, and what happens then? This neurotransmitter adrenaline that will not be able to bind to this receptor, which will lead to not any kind of contraction. So there will be no contraction in the smooth muscle. So there will be no contraction in the lumen of the blood vessel. Okay. So the lumen of the blood vessel dilate as the muscle will relax. So the lumen of the blood vessel will dilate, and that will cause the decreased blood pressure. Because if the lumen will constrict, the blood pressure will be increased. If the lumen will dilate, then the blood pressure gradually decreases. So that's how the alpha 1 blocker helps in increased blood pressure. Now, if we talk about the angiotensin converting enzyme inhibitors, so what happens in this situation? Usually what happens, so let me rub this. In our kidney, juxtaglomerular cells are present, as you all know. Over there we have the macular denser cells near the portion of DCT, distal convoluted tubules. So these macular denser cells have the baroreceptors, which can sense the low renal blood flow. So, for example, if there is low blood renal flow, that means that our kidney is not able to get the proper blood circulation. So the macular denser cells in the juxtaglomerular apparatus, the baroreceptor present on the macular denser cells will sense this low renal blood flow and will start producing renin. So in the kidney, in the juxtaglomerular apparatus present in the kidney, there are the macular denser cells. Macular denser cells, as they will sense the low renal blood flow, they will start producing the renin. So they will start producing renin. However, our liver produces angiotensinogen. That is the inactive enzyme actually. So our liver produces the enzyme. That is this is the beginning of the RAS system, Renin-Angiotensin-Aldosterone System. So what happens? That kidney will produce the renin. Actually, the macular denser cells will produce the renin in order to increase blood pressure. How they increase blood pressure physiologically? So liver will produce what? Liver will produce the angiotensinogen. Okay. So liver produces our angiotensinogen. Angiotensinogen will convert into further into the angiotensin 1. So this angiotensinogen, which was the inactive enzyme, will convert into the active enzyme with the help of this renin. So renin, what will it do? It helps angiotensinogen to convert into the angiotensin 1. Angiotensin 1. And angiotensin 1 will further convert into the angiotensin 2 with the help of angiotensin converting enzyme. Angiotensin converting enzyme, from where it comes? It comes from the lungs. So lungs have the angiotensin converting enzyme. So for example, here are our lungs. What they will produce? They will produce the angiotensin converting enzyme. They will produce the angiotensin converting enzyme, which helps angiotensinogen 1 to convert into angiotensin 2. Angiotensin 2. And now the angiotensin 2 in our blood will bind to the receptors. Angiotensin 2 receptors are present in all over our body. They are present in the arteriolar smooth muscle. They are present in venules, veins. Okay, they are also present in the adrenal cortex. Adrenal gland is present over the kidney. So there in the adrenal cortex, in the zona glomerulosa, we have the receptors for the angiotensin 2 that can bind those receptors and will start releasing from there aldosterone. Which further, what will it do? Aldosterone will suck up the sodium and water. Okay, which means aldosterone will not allow to pass sodium and water into the urine, and due to which there will be the increased blood pressure. So that is the physiological condition, and that is the renin-angiotensin-aldosterone system. That renin is produced by the kidney. Angiotensin will convert into the angiotensin 2, angiotensin 1. Angiotensin 1 will convert into angiotensin 2 with the help of ACE, angiotensin converting enzyme. And angiotensin 2 will bind to its receptors, and adrenal cortex, the zona glomerulus of adrenal cortex, produces aldosterone, okay, which will help in increasing the blood pressure by retaining sodium and water in our body. So as the sodium and water will retain in our body in order to increase blood pressure, so there will be the increased venous outflow, increased venous return to the heart. So that will cause the increased blood pressure. So this is the renin-angiotensin-aldosterone system in very brief. So what is the function of the angiotensin converting enzymes inhibitors? So angiotensin converting enzyme inhibitors, they just simply block this enzyme, angiotensin converting enzyme. Then what will it lead to? The angiotensin converting enzyme, as they will be inhibited, angiotensin 1 will not be able to convert into angiotensin 2, and if there will be the low angiotensin 2, then they will not be able to bind to its receptor very efficiently, which will further leads to decreased blood pressure, because they will not be able to bind to its receptors. For example, in the adrenal cortex, glomerulosa, as the angiotensin 2 will not bind to its receptor, aldosterone will not release into the blood. Further, there will be no retention of sodium and water, that will lead to the decrease in blood pressure. So that's how the angiotensin converting enzyme inhibitors work. That is the mechanism of action. Talking about the side effects, they cause the chronic cough. They can cause the chronic cough. They can cause angioedema. Chronic cough because of the bradykinin accumulation in the lungs. So actually this ACE, angiotensin converting enzyme, also breaks down the bradykinin into bradykinin. So the accumulation of bradykinin can lead to the chronic cough. Angioedema, headache can be also the side effect as far as angiotensin converting enzyme inhibitors are concerned. Nausea, vomiting and diarrhea. And also, in order to reducing the blood pressure, the chronic use of angiotensin converting enzyme inhibitors can lead to hypertension, which is also the side effect for ACE inhibitors. Contraindication is pregnant ladies. In pregnancy, we must not give the angiotensin converting enzyme inhibitors because they have the teratogenic effects that can lead to the various kinds of problems in the fetus. Now let's talk about the angiotensin 2 receptor blockers. It's more related to the angiotensin converting enzyme inhibitors, because angiotensin 2 receptor blockers, what they do, that it's very understood from this, that they will block the angiotensin 2 receptors. So if there will be the angiotensin 2 in the blood in proper amount, but angiotensin 2 receptors, if they will be blocked, angiotensin 2 will not be able to bind to them efficiently, and further the decrease in blood pressure. So that's how the angiotensin 2 receptor blockers work. Again, the side effects are very similar to the angiotensin converting enzyme inhibitors. They can also cause chronic cough, but ACE inhibitors have more side effect as compared to angiotensin 2 receptor blocker. So angiotensin 2 receptor blocker can also cause the headaches, nausea, vomiting, diarrhea, also the hypertension in order to reduce blood pressure in chronic cases. Now talking about the contraindication, again this should not be given in the pregnant ladies. And also the asthmatic patients and some kind of type 1 hypersensitivity reaction, that is allergy, so they must not be given. And in hypertension, already decreased blood pressure, so if you will give the herbs, or that is angiotensin 2 receptor blocker, to hypertensive patient, already it is given for the hypertension, so that will already there in the patient there is the decreased blood pressure, and if you will give herbs, then it will also decrease the blood pressure, that can be the fatal for the health of the patient. Now talking about the beta blockers. Now beta blockers, we have the beta 1 blockers and the beta 1 and beta 2 blockers. In the beta 1, talking about the drugs, alpha 1 blockers are the prazosin or doxazosin, you can say, angiotensin converting enzyme. So the ending of the alpha 1 blocker is the josin, like prazosin, doxazosin, like that. Angiotensin converting enzyme have the ending with the pril, like lisinopril, captopril, enalapril. These all are the examples for the ACE inhibitors. Talking about the herbs, angiotensin 2 receptor blockers, we have the endings with the sartan, like losartan. This is the angiotensin 2 receptor blocker. Beta blockers, we have the beta 1 blockers and the beta 2 blockers. Beta 1 blockers, as you all know, they have the suffix olol, like atenolol, talinolol, metoprolol. These all are the ending with the olol. So we have the beta 1 blockers, and the beta 1 and beta 2 blockers, okay, like carvedilol or labetalol, they are also ending with the olol, or their suffix is the olol. How the beta 1 blockers work, or the beta 1 and beta 2 both, how they are working, their mechanism of action. So let's talk about that. Actually, beta 1 receptors, first of all you should know that where are the location of the beta 1 receptors. Beta 1 receptors are actually present in our heart, adipose tissues, and the kidney. So the beta 1 receptors are present in our heart, that is you can say the pacemaker of the heart, also the atrioventricular node of the heart, myocardial cells of the heart. So for example, here I have drawn the one pacemaker. I have taken the pacemaker of the heart over here. For example, this is the pacemaker of our heart. They have the beta 1 receptors over here. Okay, this is the beta 1 receptor. So as the norepinephrine or adrenaline, that they will come to the, so this is the, for example, this is the adrenergic neuron. Okay, this is the adrenergic neuron. As the epinephrine will come over here, they will try to bind to that beta 1 receptor. So this is the beta 1 receptor present over the pacemaker of heart. So as they will bind to the beta 1 receptor, okay, as they will bind to the beta 1 receptor, that will cause the increased blood pressure. Okay, now how they increase? They will increase the heart rate, they will increase the cardiac output, they will increase the systolic volume, and eventually there will be the increase in the blood pressure. Now if we will block this receptor, that is the beta 1 receptor, so we have the beta 1 blockers. We have the beta 1 blockers. So as we will inhibit this receptor, so what will happen? That epinephrine or adrenaline will not be able to bind to this receptor. And what will it cause? It will cause the decrease in cardiac output, decrease in systolic volume, and eventually decrease in our blood pressure. So that's how they help our beta blockers, especially the beta 1 blockers. So all atenolol, metoprolol, telenolol, they work like this. Now talking about the beta 1 and beta 2 blockers, labetalol or carvedilol. Beta 2 blockers are present in the smooth muscles. So over there we have the receptors, as I already mentioned. Then over there they have the beta 2 receptors. So again, the adrenaline can bind to it, and it can cause the increase in blood pressure. So the blockage of the beta 2 receptors over there can also cause the decrease in blood pressure. Now about the beta blockers. This was about the beta blocker. Side effects, again, in the chronic use, they can cause the hypertension, they can cause bradycardia, that is slow heart rate with the chronic use. That's why we should not stop it abruptly, beta 1 blockers, because the receptors are hypersensitized. So we should gradually lower the doses of the beta 1 blockers, and that's how we treat the patient. Now talking about the calcium channel blockers. Actually we have two types of calcium channels in our body, that is T-type calcium channel blocker, T-type calcium channels, and the L-type calcium channels. So what are the types? We have the T-type calcium channels and L-type calcium channels. Now, T-type calcium channels are present in our heart, that is pacemaker of our heart, like this. So what happens, like the beta 1 receptor, we have the calcium channels also. We have the calcium channels also. These are the calcium channels, for example. So what happens, calcium, as the calcium ions due to the action potential, as the calcium ions will go inside the pacemaker or the myocardiocytes or cardiomyocytes. So what happens that as they will calcium ions enter inside the pacemaker or cardiomyocyte, that will cause the depolarization of the cell, and due to the depolarization, action potential will generate, and as the action potential will generate, that will lead to the again the cardiac output, systolic volume, and the increased blood pressure. But if we have the T-type calcium channel blockers, then what will happen? T-type calcium channel blockers, they will lead to the blockage and will lead to the decrease in cardiac output, systolic volume, and eventually the decrease in blood pressure. So they will block the calcium channels over here and helps to reduce the blood pressure. So in the T-type calcium channels, what kind of drugs we have? We have the verapamil. So verapamil is the famous drug which acts on the T-type calcium channels. However, in more doses, they can act on the L-type calcium channels too, but usually they act on the T-type calcium channels. Now, talking about the L-type calcium channels, they are present in the smooth muscle cells again. So, as the calcium will go inside, again what will happen? You know that there will be the increased blood pressure, as there will be the contraction or narrowing of the lumen, which lead to the increase in blood pressure. But as the calcium channel, L-type calcium channel will block by the drug, by the calcium channel blockers, what will happen? There will be the widening of the lumen around the smooth muscle cells. There will be the widening of the lumen, which will lead to the dropping of the blood pressure. So in L-type calcium channels, we have drugs like ending with the dipine, like Amlodipine. These are very famous drugs as far as L-type calcium channel blockers are concerned. Amlodipine and nifedipine also. So these two drugs are very popular in calcium channel blockers, especially in the L-type calcium channel blockers. And in the T-type calcium channel blockers, we have the verapamil. So this was about the calcium channel blockers. Now, let's moving on to the diuretics. All the side effects of all these drugs will be the first one will be the hypotension. In some cases, there is unique side effects, which I have already mentioned, like in the ACE inhibitors, like angioedema and the chronic cough due to the accumulation of bradykinin in the lungs. Contraindication is very important as far as ACE inhibitors and angiotensin-2 receptor blockers are concerned. That one is the pregnant ladies, because they have the teratogenic effects that can lead to the problems for the baby. So in the pregnant ladies who are suffering from the hypertension, usually ACE inhibitors and ARBs are avoided, because we have the various other choices as far as antihypertensive are concerned. By the way, the first line drugs of antihypertensive are the diuretics, which I will discuss now. Diuretics are the first line drugs. After that, we have the ACE inhibitors, and then ARBs, and then beta blockers. So diuretics, ACE inhibitors, and beta blockers are very frequently used. If any patient is not responding to these drugs, then we will move on to the other classes of the drugs, like calcium channel blockers, alpha-1 blockers, and other kinds of drugs. But the diuretics, ACE inhibitors, ARBs, and beta blockers are the first line drugs as far as antihypertensive are concerned. Now, talking about the diuretics, as we have already discussed about the calcium channel blockers, let's talk about diuretics. Now, in diuretics, we have loop diuretics, we have thiazide diuretics, we have potassium sparing diuretics. So there are the different classes of diuretics, and I will talk about them in detail in the different video about diuretics. So how they works? They actually flush out the sodium and water from our body, and that's how they are decreasing the blood pressure. Now, if you remember, aldosterone was helping in retention of the sodium and water. Water follows the sodium. If there will be the retention of the sodium, then there will be automatically there will be the retention of the water at the same time. So diuretics, what they do, they flush out the sodium from the body, and water follows the sodium, so water will also the flush out, and that's how they decrease in the blood pressure. Because as there will be the low sodium and water in the body, there will be the low blood volume, okay, low body fluid, and there will be a decreased or drop in the blood pressure. So diuretics, they flush out the sodium and water. They don't give GFR to retain the sodium and water, because if there will be the low blood flow through the PCT, so the cells or the epithelium which are present near the PCT, that is the simple cuboidal epithelium, they will retain the sodium and water from there. So diuretics won't allow them. They work on the different segments of the nephron, and they will flush out the sodium and water. For example, loop diuretics works on the loop of Henle. Potassium sparing diuretics works near the collecting duct of the nephron, and the thiazide diuretics, they works in the portion of the DCT of the nephron. So their main function is to flush out the sodium and water from the body, and that's how they decrease the body fluid, blood volume, that will lead to the drop or decrease in blood pressure. Talking about the drugs, in loop diuretics there is the furosemide. In the thiazide diuretics we have thiazides, and in the potassium sparing diuretics we have very famous drug, that is spironolactone. That leads to the sparing of the potassium, that's why it's potassium sparing. The side effects of these drugs, as far as loop diuretics and thiazide diuretics are concerned, they have the hyponatremia, hypokalemia, hypercalcemia, hyperglycemia. So hyperuricemia can lead to the risk of gout. So there can be the accumulation of the uric acid in the joints, for example. So that can lead to the increased risk of the gout. That could be the side effect as far as diuretics are concerned. In the potassium sparing diuretics, there could be the hyperkalemia, because the potassium is sparing inside our body. So that can lead to the hyperkalemia. That can lead to metabolic acidosis. Metabolic acidosis and hyperlipidemia. Metabolic acidosis can also be seen in the loop diuretics and the thiazides. Now, talking about the endothelin receptor blocker, which is the last E. Endothelin receptor blockers, they are also called as vasodilators. First, let's talk about the drugs. We have two kinds of classes in this. We have the arteriolodilators and we have arteriolo plus venodilators. So these drugs, they work on both. They dilate the arterioles as well as they dilate the venules. So talking about the arteriolodilators, so let's allow me to rub this. So what drugs comes under the category of the arteriodilators and what drugs comes under the category of the venodilators plus arteriolodilators. So for example, here are the arteriolodilators and here are the arteriolo plus venodilators. So what drugs comes under these categories? Arteriodilators, we have like minoxidil, we have diazoxide, minoxidil, we have diazoxide, okay, and we have the hydralazine. In the arteriolo plus venodilators, we have the sodium nitroprusside, which we also use in the hypertensive emergencies. Now talking about the minoxidil, how they works. Actually, these all three drugs act on the arterioles and they dilates these arterioles. How? There are the endothelin 1 receptors. So endothelin 1 will, if they will bind to it, endothelin 1, if they will bind to the endothelin receptors, that will cause the arterioconstriction and will increase the total peripheral resistance. So we need to decrease the total peripheral resistance. So how we will do it? On the arterioles, as they are the endothelin 1 receptor, we will block this receptor and will not allow the endothelin 1 to bind to its receptor efficiently. So what will it do? It will decrease the total peripheral resistance, which will lead to the decrease in diastolic blood pressure and eventually the blood pressure. So that's why we call them as vasodilators, because they cause the dilation of the arterioles and the venules. So these are specifically the arteriolodilators. So minoxidil is also used for the baldness because they causes the increase in the hairs. So they are also available in market in the topical application. So usually men's apply on the bald head and that will cause the growth. They can cause the growth of the hairs and they can cause the growth of the beard too. That's why they are contraindicated in the females. So this was about the minoxidil. Dioxide and hydrazine works similarly to this. They will cause the vasodilation. Talking about the arterial plus venodilators, they act on the venules as well as they act on the arterioles. However, they are strictly act on the arterioles only. They don't act on the venous side. So they act on the arterioles plus venules too. Sodium nitroprusside are used for the hypertensive emergencies especially. So otherwise we don't use sodium nitroprusside. Only in the emergency conditions we use the sodium nitroprusside. For example, the systolic blood pressure is about 150. So that is the emergency condition in the hypertension. So in that case we can use the sodium nitroprusside. Usually antihypertensive drugs are used in combination. Why? Because for example, if we are giving ACE inhibitors to the patient, so ACE inhibitors, okay, that will not allow angiotensin 1 convert into angiotensin 2, and angiotensin 2 will not be able to bind to the receptors, and that will cause the decrease in blood pressure. But baroreceptors are present in the macular densa cells, but they are present also in the near the carotid sinus. So what will it do? Baroreceptors will sense the low blood pressure in our body, and they will send the signals through the glossopharyngeal nerve, that is the 9th nerve, to the vasomotor center in the medulla oblongata. And what will it do? It will cause the sympathetic outflow, and sympathetic outflow will cause the more and more release of epinephrine that will lead to the binding of the epinephrine to the beta 1 blockers that are present in the heart. So that will cause the reflex tachycardia. That's why with the ACE inhibitors we give the beta blockers. Okay, beta blockers or diuretics with them. Diuretics will flush out the sodium and water, so that's how they will decrease the blood pressure. So that's all about the antihypertensives or the antihypertensive drugs, how they act, their side effects, their contraindications, their uses. So I hope you like this stuff. Thanks for watching this video. Thank you.